Hello everyone. Hello everyone. Very good evening. I'm Dr. Sunil Chindal and I take care of medical affairs and R&D for Baxter Advanced Surgery, India and South Asia. First of all, I would like to extend my warm welcome on behalf of entire Baxter team to the organizing chairperson, moderators, speakers, and participants to this webinar on adjuncts in brain tumor surgery. This session is part of our Tumor Thursday webinar series, which was conceptualized to have a very meaningful discussion around neurospinal tumors, right from basic concepts like pathology, diagnostics, and up to surgical management. Baxter Advanced Surgery team is proud to be associated with Dr. Sridhar and MGM Healthcare, and I would like to take an honor to introduce him. Dr. Sridhar is a director and group head, Institute of Neurosciences and Spinal Disorders, MGM Healthcare, Chennai. Sir is a renowned neurosurgeon with over 30 years of experience in his specialization, trained under pioneer neurosurgeons Professor P. Ramamurthy. His experience and expertise in spine surgery, brain tumor, and vascular surgery, as well as in pediatric problems, is well known. He has done pioneering work in microneurosurgery and especially in brainstem and eloquent area surgeries, including awake craniotomies and cervical spine surgeries and in neurotrauma. Without much ado, let me invite Dr. Sridhar to take over from here.
Thank you, Suneet, and welcome everybody to the 8th edition of the Tumor Thursday webinar series. We started this during the lockdown as a replacement for a program that we were scheduled to have on brain tumors in July. And then once we realized that could not happen, we started this, and thanks to Baxter, we've been able to successfully have these every month on Thursdays. We have gone through the entire gamut of tumors, and we thought we should, towards the end of this entire series, have something on adjuncts which we all use during surgeries. And this particular webinar is focused on adjuncts which is used in brain tumor surgery. So we have a very eminent and experienced faculty today. And to moderate the session, we have also very well-known people in the field of brain tumors. Professor Ashish Pathak is the Director of Neuro and Spine Surgery in Fortis Hospital, Mohali. And he's a well-known figure in all our conferences. And before that, he was in the UK, and then he's also been a faculty at PGI Chandigarh. Welcome, Professor Ashish Pathak. Professor Anand Balasubramaniam is currently the Senior Consultant and Head of Neurosurgery at Yashoda Hospital in Secunderabad, and before which he was in Mumbai at Kokilaben, and before that a faculty in NIMHANS. He is well known for his work in brain tumor surgery. Welcome, Dr. Anand Balasubramaniam, to this. The two of them would be the moderators or chairpersons of the talks. There will be 4 talks, and each one about 15-20 minutes. We request the speakers to keep to time, because after the talks would be the interactive section, the moderation, the questions, etc. Because we hope to finish on time around 8:15, 8:30. So over to the moderators to please go ahead with the session. Thank you.
Thank you, Sridhar. Dr. Ashish, please go ahead. You can take over.
Carry on. That's fine. I'm there. You carry on, please.
Yeah, I think straight away then we'll go to the first speaker according to the agenda. I think is the introduction going to be given by Dr. Sunil Chindal?
No, that's already done.
That is already done. So we directly go for the talk.
Yeah.
So I call over Dr. Ali Asghar Mayadi for his talk on intraoperative imaging. Dr. Ali, over to you.
Thank you. Just checking, can you all hear me?
Yeah, we can hear you.
Okay. Thank you, Dr. Anand. Thank you, Dr. Ashish. Thank you, Dr. Sridhar and the entire team. Dr. Sridhar asked me to speak on my experience with intraoperative imaging and the way I do it during brain tumor surgeries. And I'm going to therefore focus a lot more on the intraoperative ultrasound. That's what I use very frequently during tumor surgeries. So, sorry. So all of us neurosurgeons deal with gliomas and tumors day in and day out. Gliomas probably constituting a very large chunk of the entire gamut of tumors that we treat, and they come in all shapes and sizes. The common thing between all gliomas is that there is a very significant role, prognostic role of the extent of resection. And that is something as neurosurgeons which we are able to modify. And that is the basic underlying tenet in glioma surgeries or tumor surgeries, is to maximize the resection, of course, safe maximal resection. But that is easier said than done. Very often we set out with a goal of achieving a gross total resection, or at least we anticipate and expect that we would get a gross total resection. And we've all faced this situation that we land up with a surprise and that we always realize there is some tumor which is left behind. And this is not just anecdotal experience all of us may have had, but this is actually shown multiple times in many studies in literature. And this is just one of them which I'm quoting, where they looked at all possible potentially resectable tumors, which means you should have got a gross total resection. And they found that the postoperative MRI, in spite of the surgeon having reported a gross total resection, showed a residue in almost 70% of the cases, which is actually a very significant discrepancy between your planned extent of resection, that is your intent, and the actual extent of resection that you're able to achieve, the outcome. And that is why all of us have embraced a lot of adjuncts. This entire symposium is based on that. These adjuncts together allow you to achieve an oncofunctional balance, that is to be able to maximize resection at the same time to preserve functionality. And we all use this in various combinations, and you're going to hear about quite a few of them today. So there are adjuncts which help you maximize resection, which includes image guidance, navigation, and intraoperative imaging. And then there is optical imaging, which is a different kind of visualization. Though I use this often in high-grade gliomas, I'm not going to talk about it today. And then you have the functional brain mapping, either under anesthesia or awake. So just a brief note on navigation, that it's something all of us use, and most neurosurgical ORs, if not all, would have a navigation system. And we all know how that works, like a GPS system, and it navigates or guides you or guides the neurosurgeon during the procedure. And we use this quite frequently. And in tumor surgeries, it has actually, it has a significant role in allowing you to plan the craniotomy. That's what we do. Of course, again, a caveat here that a lot of experienced surgeons may not require a navigation to plan the craniotomy, but it helps you customize it for sure. And it also actually helps you to understand the relationship of the tumor with respect to a lot of eloquent structures. As I said, functionality and preserving function is very important. And I usually like to use this by segmenting the tumor and then the respective cortical regions and the tracts. And then if you actually, you can play around a little bit with it, position it virtually in the way that you're going to do the craniotomy and understand or simulate the surgery. For example, here is the motor strip, the corticospinal tract, the arcuate, I4 of uncinate, and an awake case. And then you can actually even do a virtual craniotomy while before you actually start off, in order to anticipate the surgical steps and be prepared for them. However, we also all realize that there is this phenomenon of brain shift, and therefore navigation is good for the planning, and it actually gives you good guide points. But then once the brain shift sets in, the accuracy is compromised, and therefore you need something else to be able to update that. And that's where real-time intraoperative imaging comes into the picture. Just a slide about intraoperative MRI. I don't use it, but I think we must appreciate and understand that intraoperative MRI remains the gold standard for intraoperative imaging, especially in tumors. And this has been shown in its evidence-based. It is also real-time, actually quasi-real-time, because you need to shift the patient to the scanner or get the scanner and do the scan and then proceed with surgery. Surgery is interrupted for a short while. The problems being that the logistics, the long times of acquisition, Of course, the cost and the infrastructure which is required, and the significant alteration in the surgical workflow that happens during an intraoperative scan is sometimes the challenge, which makes it a little less attractive and convenient. On the other hand, the intraoperative ultrasound is actually something very convenient, easy to use. And compared to the MRI, it definitely is cost effective. It's been grossly underutilized in neurosurgery. And I can take you through our experience to show you how it can be, the utility can be maximized. So I think a lot of the reluctance and the hesitation for neurosurgeons was based on historical experience, where you had these kind of scanners and these big probes, which led to poor image quality and resolution. With the advent of CT and MRI, all this became actually very redundant. However, in the last decade or two, there has been an exponential revolution in the quality of the scanners. You have sleek ultrasound scanners now, and you actually have customized probes. Ultrasound companies are now investing in specific cranial probes, understanding the potential of the role of this intraoperative imaging modality. And there are certain unique designs of the probes which make it actually very conducive to doing insonations in uneven cavities and in the brain, which is a delicate organ. Besides that, the interface of the machine is also very, very user-friendly now, with a few controls, a lot of them digitized, which makes it convenient for the neurosurgeon to operate it. Because remember, the ultrasound is something you need to operate in order to get familiar and to extract its maximum benefit. And this has actually opened up new vistas in the application of intraoperative MRI, not only tumor surgery, but different subspecialties of neurosurgery can use it. And I'm not going to talk about it, but there is enough experience and evidence to show its utility there. Just to make a head-to-head comparison between the ultrasound and intraoperative MRI, as I said, there is no doubt that in terms of image resolution, a full head view and orientation, the intraoperative MRI is absolutely unbeatable. The ultrasound has its limitations in terms of its resolution, which is now improving with newer machines, specific cranial probes which have tunable frequencies. And if you couple it with navigation, and I'll show you that, the orientation problem can be solved. It does require, it is subjective interpretation as well as acquisition of ultrasound is subjective. However, training can shorten the curve, and then you can actually maximize all the other benefits that the ultrasound has in terms of convenience, ease of workflow, does not interrupt surgical workflow, especially if you're doing multimodal glioma surgery with intraoperative mapping or awake surgery. And it is it's actually light on the pocket. I looked at literature to see if there was a direct comparison between intraoperative MRI and intraoperative ultrasound, and there are very few studies, and this is one of them, which looked to compare the accuracy of intraoperative ultrasound, navigated ultrasound, in the same patients with intraoperative MRI. And actually, this group also looked at ALA fluorescence in a set of glioblastomas. And what they did was they used all three modalities. They took biopsies and labeled the biopsies depending on what the interpretation of the respective modality was, and compared it with pathology. And what they found, and I've just boxed that, is that the ultrasound actually scored very well. That when there was tumor, solid tumor, now we're not talking of infiltrating and the edge, which sometimes is very, very difficult to pick up. But even in terms of the solid tumor, the ultrasound actually had the maximum positive concordance. This is not to say that the ultrasound is better than the others, but it is actually equally good, if not better. This is a small study, but there are enough other studies, assessing individual modalities, that the ultrasound is not bad. It has a decent accuracy, the caveat being that you have to acquire it and interpret it well. In our own experience, we found it extremely useful as a multifaceted tool for different aspects of glioma surgery, be it identifying the lesion, could be just for biopsy, just for delineating the lesion and planning the resection control, or for even orienting yourself in the anatomy and the surrounding structures. We've used it for various applications, including biopsies, including resections, and we specifically find it very useful in non-enhancing tumors where it is actually the other modalities. For example, ALA does not work too well. And it lends itself very well to get integrated into multimodal glioma surgery, as I mentioned already, where you could use it with ALA fluorescence and with awake surgeries very, very easily and very, very conveniently. To reinforce that the benefit of the ultrasound remains in acquiring a good ultrasound image. And the better the image, the better your interpretation, and obviously better the outcomes with use of ultrasound during tumor surgery. Be aware that during surgery, as you proceed with resection, there are artifacts which creep in because of microcontusions, debris, hemorrhage, and these can actually mask the residue as well as create some artifacts which may be very, very disturbing and difficult to interpret, especially for somebody who's on the ascending part of the learning curve. This is something which you have to be aware of and which needs to be learned by experience. A lot of the challenges and hurdles in acquiring intraoperative ultrasound are related to the person as well as with the machine, lack of familiarity or use of the wrong probes, and actually a lot of them are correctable. And this is why practical training is important in terms of understanding the basics theoretically, but also applying it either on models or in simulations. Regardless of training, we must also appreciate the fact that 2D ultrasound, and all of us, or most of us would have used 2D ultrasound, which is the standard ultrasound mode, live 2D mode. It poses problems, as I've already alluded to, in giving you unconventional planes of imaging. It doesn't give you true anatomical planes. It doesn't give you a full head view. That causes lack of orientation. And therefore, because of that orientation problem, becomes difficult to interpret images, especially if you're going to do them serially during, say, resection control. And that's where navigated ultrasound steps in, which combines the benefits of a 2D ultrasound, a really good real-time imaging, plus navigation, image guidance. And there, these systems will help you, it could be used as standalone navigation, as well as for using repeated updates of the intraoperative ultrasound. And a lot of the navigation systems now allow you to integrate many standalone ultrasound systems. This is one of the systems we've been using for a long time, Sono One system. And more recently, we've been using a combination of this system, which is a Brain Lab, along with the BK ultrasound digitally integrated into 3D navigation. So what it does, navigated ultrasound, is that it allows you to co-display images, be it MR with ultrasound, be it ultrasound with ultrasound serially taken, pre-resection, intermediate, post-resection. And because it gives you multiplanar image display, you could orient it in anatomical axial coronal sagittals, and you could actually orient all the serial scans also in the same planes. It gives you, it improves your orientation, improves your interpretation. And you can also leverage the advantage of MRI, that is functional information like DTI and fMRI data, which can be used along with the ultrasound then. Importantly, ultrasound can compensate for the brain shift. However, when I say compensate, most of the systems right now will show you the brain shift, and then you have to manually account for that rather than an automatic compensation, though I'm aware that a lot of systems are working on an automatic system too. But remember again that the basic 2D ultrasound still needs to be acquired well, because navigation will not change the image resolution for you. Just to give you an example of how navigated ultrasound would look like, this is on the same navigation system. You go to the ultrasound mode, and here we are doing ultrasound in live 2D mode. So you can see this is how the ultrasound looks. By having the navigation, you can superimpose it and look at the screen over here on the left. You can actually see the plane in which you're insonating. This is a navigated 2D ultrasound, because right now you're doing it in live 2D mode. And now we switch to 3D mode, and using the same sweep, you acquire a 3D sweep. So you're just sweeping it across the tumor, and it acquires a complete 3D, which within less than a minute processes it completely. And then the system actually on its own reorients it into whatever desired plane you have. So now you have this was the MRI. I'm sorry for that, just went too fast. So yeah, so here you have the MRI, and this is that MR with the ultrasound code displayed. And if you can appreciate, there has already been a brain shift. You can look at the Fox on the ultrasound and the MR. And you could also display this in any other planes that you wish to, or even the ultrasound directly. Then you can proceed with your resection, and then you do a post-resection ultrasound. And this is again a 3D being acquired. This is the cavity being insonated, scanned. And again, you process it, have a 3D, and then when you navigate, sorry, for some reason that does not come there. You can actually view the cavity side by side with the pre-resection ultrasound scans. So what that helps you do is that it helps you improve your orientation. For example, here, you have the pre-resection ultrasound, you have an intermediate one where you're seeing a rim of tumor, and then you have a final resection where you can appreciate that that hyperechoic rim is out. This is actually a very important aspect of using ultrasound for tumor resection control and using it in serial manner with intermediate scans. And that is what actually gives the benefit to an intraoperative imaging tool. And this is again where the ultrasound would score over, say, MRI, which you would be very reluctant to use twice or thrice to get that. But it's very good, the MRI, for doing a final check scan. So in our experience,
15 minutes are up if you can.
Yeah, I'm just going to wind up in next. I have 2 more slides, I think, 2 or 3 more slides.
Thank you.
So what we looked at was almost 200 scans in which we had 115 intermediate scans. And I just want you to focus on this, is that in 49 cases, we had not anticipated a residue, but it was picked up by the intraoperative imaging in 47. So this may be the case even with MRI. The point is here that intraoperative imaging picks up a lot of unanticipated residues, and that is where it helps. And this actually helps improve your gross total resection rates, where we had a decent concordance with MRI. And there we had a diagnostic accuracy in the range of 80s to 90s. This is also seen in literature. To sum up, if you were to use intraoperative imaging, be it any modality, these are the points that you would want to cover in order to minimize the errors of leaving unanticipated residue or avoiding any kind of complication. And the ultrasound actually ticks most of these boxes. It does not, however, help you plan the craniotomy, but if you combine it with navigation, then it can cover all these bases, and you have a very good tool, comprehensive tool for tumor surgery. And this is my final slide. So the way I would look at it is that the ultrasound, navigation, all of them combined together into so you have a kind of a menu, a cafeteria approach, where you have these modalities available. Each of them has their pros and cons, their advantages and disadvantages. And if you use them judiciously, use them wisely, then you could extract the maximum benefit from them. So thank you very much. Sorry for just overshooting the time.
Thank you so much, Dr. Ali. That was a wonderful presentation as usual, especially of the navigable ultrasound. I realize you got a new toy. It's Brain Labs over your previous Electa system, which you had.
Yeah.
Yeah, so it's nice to see the wonderful images. We'll take the discussion up in the end. I think we'll move on to the next topic. Next topic is by Dr. Ponnaya.
Yeah, thank you, sir.
Yeah, please carry on.
Yeah, I think you can see my screen.
Yeah, we can.
Yeah, thank you so much, sir, for inviting me to give this talk. So in this talk, we'll talk about awake craniotomy as an adjunct to tumor surgeries. As we all know, we get patients like this who has right-sided mild weakness, and there is a motor cortex tumor, and a young male with seizures, with speech disturbances, and there is an insular lesion. And the aim of the surgery in all these patients is radical excision of the lesion, but without increasing the neurological deficit. So that being the primary goal, these lesions are worked up by imaging and advanced imaging like functional MRI and diffusion tensor imaging. And having all these images, they give the static image of the function of the brain, function of the tracts. But even with all these images, we are doing awake craniotomy. So why awake craniotomy is the next question. We need to have an inline knowledge as the surgery is on. Like we discussed in the previous topic also, there is a static brain shift which happens during the surgery, and these images give only a static information, and they do have their own sensitivities and specificities and accuracy, and they are considered individually inferior when compared to intraoperative awake functional testing and cortical stimulation. So that's why the awake craniotomy is still on, although it is not a new procedure, it's a very old procedure. It is still on, and it has advanced in a way that it can be used in all eloquent lesion surgeries. So now it is a multimodal approach where we are using imaging, advanced imaging, along with intraoperative neuronavigation, intraoperative imaging, with the conscious sedation, awake craniotomy, including functional intraoperative testing and intraoperative cortical mapping for the language and motor function. So that is how the current norm and current standard is. That is how we try to preserve the function of the patient, yet removing the lesion as much as possible. So historically, we all know the awake craniotomy started with epilepsy surgeries. By avoiding anesthetic agents, we are able to do EEG monitoring, and we are able to localize the epileptic focus. And now it's being used for almost all eloquent surgeries, including tumor and vascular lesions. So it is preferred when the area to be resected is close to the motor cortex or the speech area. The surgical approach aims to maximize the lesion resection while sparing the important aspects of the brain. Having said that, there are also reports which say that by using awake craniotomy, actually we don't go for a maximal resection, and the resection is always minimal. The advantage, however, is it allows removal of the lesions in electron areas, and also it allows the to maximize the excision. That is the aim of the surgery, even in malignant lesions. So along with intraoperative functional testing, intraoperative brain mapping also is used during awake craniotomy. It identifies the regions of language representation, especially in the dominant cerebral hemisphere and the motor cortex of either hemisphere. So intraop mapping helps distinguish between eloquent cortex and the tumor tissue, which facilitates assessing the tumor from the safest cortical route, aggressive tumor resection while preserving the functional tissue. When it comes to language, it is indicated if the surgical site is near language associated cortical sites or the speech areas in the Broca's or the Wernicke's area. It can be elicited by direct electrical stimulation of the cortex during the language talks while observing for speech hesitation, arrest, or dysnomia. So that is how the language area is mapped. While the motor area can be mapped by identifying the phase reversal in SSCP or by direct electrical stimulation to the cortex and eliciting the motor movement, or by low voltage MEPs, which can be used to map the subcortical motor areas. The positive findings in that case would be inability to make specific movements when commanded, or presence of involuntary movements. So apart from functional mapping, functional testing, we also use brain mapping for the motor cortex and the speech areas. So if there is any absolute contraindication, it will be an uncooperative patient or a patient whom we will not be able to effectively communicate, especially younger children less than 14 years. Having said that, even in younger children, awake craniotomy has been safely performed. Or if there is marked confusion, confused neurological state is the baseline of the patient. Yes, obesity, highly vascular lesion, and obstructive sleep apnea are are relative contraindications. And if required, if deemed necessary, even with a modified technique by using an airway or using an awake, sleep awake technique, we can still sleep awake, sleep technique, we can still use awake craniotomy in this patient population. They are not, there are no more absolute contraindications. So the most important thing is the preoperative patient preparation, obtaining the patient's confidence and agreement to cooperate during the surgery, which is very vital, and developing a good rapport with the patient and their family, and explaining them the importance of such a procedure while the patient is awake. And also we need to be committed. We need to ensure the patient's safety throughout the surgery, and also we need to make sure that the patient is in utmost comfort during the entire procedure, including thermal comfort. So the essentials would be for a successful awake craniotomy, a cooperative patient, counseling of the patient by the surgeon and the anesthesiologist on the procedure, and a coordinated teamwork between the surgical and the anesthesia team. So always patient selection is very important. One of the most important factor where the awake craniotomies can fail intraoperatively is improper patient selection. We need to, it's important to select a motivated and a mature patient. Also, we need to be aware of the airway. We need to especially get a history of intubation history or airway examination. If it is found to be difficult, then we need to have a relook at the procedure, because intraoperatively handling the airway with the patient head fixed in a pin, it could be a bit complicated. So we need to spend more time actually preoperatively in preparing such patients. The procedure has to be carefully explained step by step, including how the patient will be shifted to the operation theater, what to expect in the operating room, and what are the things which will be in the operating room. Even a minute detail like the sound, which the vibrating noise which the drill will produce, that has to be explained clearly to the patient, so that it reduces their anxiety and they'll be very cooperative for the procedure. And preoperative medications, including sedatives and anxiolytics, are not a replacement for a thorough counseling, preoperative counseling. A thorough explanation itself provides superior anxiolysis, and we hardly use any preoperative medications or pre-medications to calm down the patients. Although benzodiazepines, opioids, and alpha-2 agonists like dexmedetomidine can be used, it's preferable not to use midazolam and other benzodiazepines, because it can produce a confused state where we will not be able to have a clear-headed recovery from the patient during the awake state for cooperation during the examination. Dexmedetomidine and a small dose of opioids or painkillers has been used. Apart from that, the patient will be receiving their routine anticonvulsants, steroids, and other medications which they usually get for the routine tumor workup. So in the operating room, yes, there should be a complete setup. We should have a airway equipment ready in case of we need to secure the airway intraoperatively. That has to be always there, including an LMA, including IGL, and including alternative ways to secure the airway, including advanced laryngoscopes, video laryngoscopes, everything. Comfort measures, warmer blankets, because the OT environment is very cool, we know, pillows to rest their legs, and reduced noise, or if the patient is fond of music, we can use other non-pharmacological things like music. And always anticipate the patient positioning. We need to have full access to the patient's face, the airway. It has to be in the line of vision always. And most of the times people have the tendency to open the operating room door and come inside, so a signage is placed so that it minimizes the movement into the operating theater. And the anesthetic management, whatever the technique we use, is to have a comfortable patient and alert and cooperative patient for a neurological testing. There are different ways we can do an awake craniotomy, and different people have their own way of doing that. But the two main techniques are the asleep technique, with or without using a airway during the asleep phase, or a monitored anesthetic technique where an airway is not used. We produce a conscious sedation and decrease the sedation during the phase where we have to test the patient, or where the patient has to be fully awake and cooperative for the intraoperative functional testing and motor and speech mapping. So what happens here is, in the monitored anesthesia care technique, the patient is sedated, he is breathing spontaneously, and he is sedated to a stage where he is responsive to the name calling, and oxygen is usually supplemented through a cannula or a face mask. And in asleep technique, a deep sedation is being given, especially during the scat block and when the patient's head is fixed in the frame, or even a general anesthetic is administered, and airway usually is an LMA, and although intubation also has been described in few scenarios, but most commonly an LMA is used, and the patient may be spontaneously breathing or controlled ventilation will be initiated. and the patient is awakened and usually extubated or the LMA is removed during the functional testing and the cortical mapping and when the tumor resection is going on. So these are the two ways where we can do an awake craniotomy. Usually we prefer a technique where we do not use any airway adjunct or any deep sedation like deep asleep awake sleep technique. We usually use very mild to moderate sedation with a good scalp block, and it is more than enough in most of our patients. Maybe in obese patient or patient who history of sleep apnea where they don't even tolerate a moderate degree of sedation, maybe we have to use deep sedation and secure the airway with the help of an LMA, and then we have to bring them awake during testing. So different institutions have different preferences for using airway adjuncts. Sometimes the patient anatomy permits, nothing is used. High flow nasal oxygen is coming up in a big way, which is being used nowadays. There are ways to get an ETCO to sample also. We use a different technique where we get a proper ETCO to waveform, but there are techniques which has been described where they use nasopharyngeal airways. Sometimes they use two nasopharyngeal airways. Patients with history of sleep apnea, even BiPAP or CPAP can be used. But remember that we cannot place any head straps, and those utilities are a bit limited. And always we need to make sure that it doesn't hinder with the surgical field. There are techniques which have been described where we can get a better ETCO to waveform, because usually when an ETCO to waveform is when a patient gets sedated, that's impossible to monitor the patient's respiration. Bilateral nasopharyngeal airway is a technique which has been described by few others, but however, we use a small infant feeding tube, just we put it to the nose directly, and you get a beautiful waveform like this, as if the patient is being in a controlled ventilation, and it remains throughout the procedure in most of the instances without any blockade from the moisture or anything. That's very important to monitor the breathing during the surgery. Apart from that, the other routine monitors are the ECG, NIBP, which is used, and very rarely we use invasive lines. And some of the institutions prefer using invasive lines, including an arterial catheter or a central venous catheter, but we don't prefer to use that, and it might be too exhaustive for the patient, and we might lose the patient cooperation during all those procedures. Catheter, yes, because intraoperatively we plan to use diuretics, mannitol, so a Foley's catheter is.
Sorry, Dr. Punaya, last minute, please.
Yes, sir.
Last 1 minute for you.
Oh, okay, last 1 minute.
Yeah, it's going to be 15 minutes.
All right, okay, sir, right. I'll just complete it.
Yeah, thank you.
So we use depth of anesthesia monitoring, including BIS or entropy. Local anesthesia is used during the dural opening. Sedatives like propofol, fentanyl, remifentanil, dexmedetomidine are routinely used for this procedure. And as I told you, non-pharmacological management is being used. So whatever may be the technique we use, the success rates are quite high, and the airway craniotomy failure rates are very, very less. Scalp block is the commonly administered technique to provide anesthesia for the scalp, and these are the nerves which we block: the supraorbital, supratrochlear, zygomaticotemporal, auriculotemporal, greater occipital, lesser occipital, and the retroauricular nerve. Usually, bupivacaine is used. Along with that, we add adrenaline for providing a long-lasting anesthesia. So these are the techniques by which we give the scalp block. I just rushed through that. So intraoperative head fixation is done. Maybe we can deepen the sedation during this phase. And the draping should allow open geometry so that will be able to see the patient face, and we'll be able to access the airway in case if it is necessary. And a moderate sedation with the help of entropy or a BIS is maintained between 60 to 80. There are some others who does not routinely administer mannitol, but we routinely administer mannitol. Craniotomy is being done before dural incision. Lignocaine is instilled, And during the awake phase, we do the testing, cortical mapping, and the sedation is completely stopped. And the patient's functional testing is started during the procedure. Speech and motor functions are being assessed, and the surgery is happening. So during the dural closure, we can come to a sleep technique. We can deepen the patient so that the patient is comfortable. Recovery is immediate, and immediately we can converse with the patient. The ICU hospital stay are, although comparable with other cases, the pain control, especially the pain medications, are significantly reduced post-operatively, and post-operative nausea and vomiting is also significantly reduced. So we can have complications, especially complications like intraoperative seizures, where we can use cold saline to abruptly stop the seizures. Intraoperative brain swelling, we can voluntarily allow the patient to hyperventilate, or we can use diuretics, or we can modify the craniotomy to allow a larger space in order to accommodate the edema. So the essential is the knowledge, expertise, experience, and a teamwork, and more importantly, a cooperative patient. And the awake craniotomy thing is rather expanding, with even younger children getting awake craniotomy successfully done, especially if they are mature enough to understand the technique. And there are reports of awake clipping of cerebral aneurysms and awake microvascular decompressions, although they have to be, they are yet to become more common and more routinely used. Generally, the patients are very satisfied, and even in children, there is no post-traumatic stress disorder after an awake craniotomy. As I told you, it has a better brain profile. And in conclusion, it has advantage with respect to patient outcomes. Patient selection and preoperative preparation is most important. Personal experience to choose the technique, careful planning, and attention are the basis of obtaining the good results. Thank you, sir. I conclude this talk with this slide.
Thank you, Dr. Punnaya. That was a very nice summary of all the awake craniotomy techniques, anesthetics used, and all the precautions to be taken. Now, Dr. Ashish, you want to call upon the next two speakers?
Right. I think the next speaker is Professor Sridhar. So, Sridhar, you're going to give a talk on advanced neuroimaging and brain tumor surgery. Is that right?
Yes.
Yes. So, please go ahead.
I've now shared my screen. Is it visible?
Yeah,
Yeah.
it's visible.
Okay. So thank you very much, Ashish and Anand. So I'll be talking on the role of advanced neuroimaging in the management of interaxial brain tumors. So majority of us, we see MRIs and CT scans and we identify the tumor. But what is important, I think, is, as we have heard, is that we need to identify the functionally eloquent areas, and also identify connections between different areas of the brain which are important for postoperative morbidity and long-term outcomes quality wise. And depending on that, we need to plan surgical approaches so that we avoid, when we operate, a disruption of connections and networks. And the main two advanced MRI techniques that I'm going to be touching on is the DTI and the Fmri. So basically, the diffusion tensor imaging, also called tractography or white matter imaging, and Fmri are the two commonly used advanced imaging techniques preoperatively. So what is diffusion tensor imaging? So basically, it looks at the movement of water molecules. And when the movement of water molecules is in the direction of the axons, then it's called anisotropic. And that is what we need to see. And what happens is that when the MRI magnet orientation is changed, what is seen is how the water molecules change in their orientation. And then we get three vectors, which are called the eigenvalues, or three eigenvectors. And with that, we get what is called the fractional anisotropy value. So basically, what as neurosurgeons we need to understand is the FA value, which is derived from these scans. And if it is 1, it is close to anisotropy, which is good. If it is close to 0, it is isotropy, which is not very good. This is the fractional anisotropy is what is generally used when we do a DTI. Also, the ADC, or the apparent coefficient, diffusion coefficient, can be measured, which is the magnitude of diffusion of water molecules within tissue, which is also a value which can be used, but most often, majority of people use the FA values. So this is how there are 3 steps to acquire this, which is done most often by our neuroradiology colleagues. But it is useful to understand how they do this so that we can participate in the getting of this information. So the basic tracts which can be looked at are the projection tracts, the association tracts, and the commissural tracts. The projection tracts are those which connect the cortex with other areas of the brain, for example, the corticospinal tract, the medial lemniscus, and the optic radiation. Association fibers connect different areas in the same hemisphere, and you can actually look at any of these tracts in your MRI with the help of your neuroradiology colleagues, and look at how they are affected by the tumor. And this particular article was a landmark article on DTI, and majority of the work currently that we know is based on this article, where it even gives you the anatomical correlates of the DTI images so that we understand exactly which tract we are looking at. And I think for those who are into looking at DTIs, I think this is a very, very important article to read. So you get beautiful images like this, which you can look at. This is a normal anatomy, so that when you understand normal anatomy, then you can understand what happens. So this is what we get actually with patients. This is both the corticospinal tracts. This is the corpus callosum, and this is in the normal pons. Now, the usefulness of DTI in interaxial tumors is that the pathological anatomy of the tracts is seen, and therefore this basically, in my mind, helps us a lot in deciding the route of approach to these tumors, so that we don't disrupt or go through important tracts. The second point is the involvement of fiber tracts by the tumor, which also then can prognosticate how will be the recovery of the patient's neurological deficit. And third is also the FA values of the lesion are sometimes we are able to correlate the prognostication with the FA values of the lesions. So therefore, it's also important that we need to know about the white matter tractography, because it is not only for the acute postoperative phase, but also for long-term surgical outcome, because this also helps in neurorehabilitation. A lot of work has gone on into this, and with this work, we now recognize 4 patterns of abnormal tract involvement on DTI. One is where the tracts are just pushed away or deviated. One is where the tracts are edematous, they are involved but only edematous. The third is where they are infiltrated but still present. And fourth is when they are completely destroyed. So these are the 4 types of involvement of these tracts. Now, an example of how we can plan a surgical approach. This is a 35-year-old lady with focal seizures, a right parietal lesion close to the medial cortical surface. And this is the DTI that we got, the coronal images. You can see that the corticospinal tracts are here. Now, what we thought was that if we were going to go through this area, there would be a problem in that the fanning out of the corticospinal tract here would give us a problem of entry into this interhemispheric space. And also we would have to retract a lot to get to the lateral boundary of this lesion. And therefore, what we did was using navigation, we decided on going to a contralateral interhemispheric approach, where we went to the opposite side, went interhemispheric, and then reached the lesion, as you can see in these intraoperative images, and then got the lesion out. So this is the postoperative scan. This is the patient in the immediate postoperative period. It was relatively easily done, and I think the patient did very well. I think the DTI approach helped us plan this lesion very well. Another lesion, a 35-year-old male, the left-sided medial temporal lesion with a large cyst and a small nodule there. What seemed to be a reasonably simple lesion to approach and remove. But when we did the DTI, we found that the corticospinal tracts were pushed medially. Laterally was the inferior fronto-occipital fasciculus. Inferiorly was the inferior longitudinal fasciculus. So basically what was happening was that the lesion was surrounded by major fiber tracts on all sides except near the sylvian fissure. And that's when we decided that what we should do is approach the tumor through the sylvian fissure and then in here directly into the cyst and then get this mural nodule out. And that's what we did. This was an interesting paper which emphasized the preservation of the articulate fasciculus and the superior longitudinal fasciculus to preserve postoperative language. And I think this is very, very important. When we operate, we often look only at the language areas and speech areas, but often forget that some of these connections and fasciculus are important for postoperative morbidity. And therefore, it is important that we do not disturb these fasciculus and preserve them. And this is, I think, very, very important. So this is what we did. The tumor was ultimately a pilocytic astrocytoma, and therefore the patient did well. Your long-term follow-up, and the patient has done well. A typical insular glioma, and we can see that the anterior and posterior limbs of the internal capsule, the anterior limb is partly involved. There is some infiltration of the posterior limb by the tumor. There is the inferior fronto-occipital fasciculus was destroyed, and the external capsule was edematous. So knowing all this, we then plan surgery. We are able to prognosticate how the patient's neurology is going to be post-operatively. We were able to maximally do a maximal safe resection of this, and 2 years, it's stable disease. We're following up the patient currently. Now, this particular paper in 2016 actually said in 27 patients that white matter-based tractography-based surgical planning can represent a safe alternative to AVIC surgery. I don't know whether it is actually true, but the importance given to white matter tractography preoperative in the preoperative planning is so much that this is what people have said. Sometimes it's very interesting when we see these butterfly gliomas, either anterior or posterior, like this, and then we can see that the corpus callosum, and to the extent to which actually the callosal fibers are infiltrated. In this, it was the corpus callosum was not seen, but in many you can actually see that the corpus callosum is not completely infiltrated or destroyed, but almost half of it is preserved, and therefore you can take a surgical decision on what you're going to do and how much you're going to do based on these. The brainstem is another important area where DTI helps a lot, because in tumors like this, you can really decide whether the lesion is circumscribed or whether it is infiltrating the brainstem fibers. This was a eye-opener of a case for us in an 8-year-old girl. It looks like a diffuse spontaneous glioma. Now, this is a typical DTI of the brainstem, of the pons, which shows the corticospinal tracts, the transverse pontine fibers, and then the medial longitudinal fasciculus, medial lemniscus, sorry. And then in this particular patient, everything was pushed back. There was a minimal edema of the corticospinal tracts by reduction of the FA value, but otherwise all the tracts were pushed posteriorly, and in our tractography, while this is the normal, this is what we saw. There was some involvement of fibers here, but otherwise majority of fibers were okay. So we went in and operated on this patient, and the patient actually improved the child's neurology improved. The child, of course, underwent radiation therapy post and is on follow-up currently. We actually published this saying that perhaps we should look at diffusion tensor imaging and tractography in these patients as a determinant of resectability. And perhaps there's a new subtype which we should not just go by the MRI scans, but we should also do the DTI to determine whether we should operate on these patients or not. Now, DTI is also very important in cranial nerve tumors, especially in acoustics and other tumors, to look at the facial nerve and other nerves, their involvement. You can see that here the facial nerve majority is going that way, but there are a few fibers also going this way. Very often, sometimes you can't see it properly, but then I think it is a useful thing to have before you operate on large acoustic schwannomas. For example, in this tumor, you could see the fifth nerve beautifully draped on the superior pole, but the seventh nerve was just a few fibers seen there. But knowing where it was, we were able to anatomically preserve the facial nerve, and patient has a grade 3 facial function, but we're just keeping a watch on the patient. The problems, of course, with DTI is that there are a lot of artifacts possible, especially when there is blood or hemosiderin there in the lesion. For example, this is a cavernoma of the brainstem, and you can see how badly, I mean, you really can't see this very well. So this is another brainstem lesion where there was blood and we could not see the tracts at all. So there are problems with DTI. The other problems is that it cannot identify projections which turn, and therefore axons which bend or fan or change direction are not picked up, and that is the problem with the current DTI that we have, and there may be a lot of noise which may result in erroneous tracking results. Therefore, people have come up with other solutions like the Hardy, which is the high angular resolution imaging, or even which supposed to give us better resolution, especially of the fanning images like this, which shows you the entire the fibers going right up to the cortex. So this is the constrained spherical deconvolution tractography method. But basically, all of them talk about looking at the tracts as best as we can. Coming on now to the functional MRI, Dr. Ponea just touched upon it, and so did Dr. Ali. But this basically looks at the increased ratio of oxyhemoglobin to deoxyhemoglobin, depending on the cerebral blood flow, which changes during a task performance. And this is what we look at basically to see where different functions are. The advantage over the brain mapping technique is that it's non-invasive. We can look at it pre-surgically, and therefore we can look at the whole brain rather than only that area exposed by craniotomy, and we don't have to do large craniotomies for removing a smallish tumor. And of course, now more and more information is available about fMRI. This is the language fMRI, which is plotted from this publication. You can see this is basically, I have put it here to see the number of areas which are involved in language. And therefore, when we actually do an fMRI for speech, unless we do and get all this information, we are not really doing the right thing. For example, this is a patient that we did for this tumor here, and what we found that while the hand activation area was quite far away, the speech activation was along the posterior border, and the lip pouting was somewhere near. So there are some parts of speech activation which may be involved, but we have not got the entire spectrum of language in this particular patient, and those are problems because they need special software to identify these areas. But can be of help when you look at DTI and functional MRI together. For example, in this recurrent oligodendroglioma, in this patient who already required RT right on the motor strip or just below the motor strip, we found that the hand and foot were very close to the lesion. The DTI showed that the fibers were a little separated, but right there. And therefore, we use navigation with cortical and subcortical stimulation to try and get out as much of the tumor as possible. It turned out to be an oligodendroglioma grade 1 with 1p19q codeletion. He received temozolomide after this, but we are keeping a watch on him.
Dr.
So
Sridhar, your 15 minutes, I'm afraid it's over. Yeah, thank you.
Last slide. So basically what people are saying now is that this helps in the extent of resection and improves the extent of resection. And therefore, if you add on to these, the tools that we have in the operation theater, including navigation, all the electrophysiological tools, the surgery becomes much, much better. So white matter based tractography based surgery is currently recognized as a valuable tool for balancing the trade-off between functional preservation and maximized resection. Is there anything new? The only thing new possible is radionomics, where we can perhaps look at predict glioma immunohistochemistry for a more precise management. Thank you very much.
Thank you, Dr. Sridhar, for a very elaborate discussion on imaging, advances in imaging. And that was really very useful and present in a very comprehensive way. We'll have questions at the later part of the session. So may I now have the pleasure to request Dr. Pragya Sarma to give his talk on role of adjuncts between hemostats and sealants in neurosurgery. Dr. Sarma, please.
Thank you, sir. So am I visible, sir?
Yeah, you're visible.
Your slides
Okay.
and you put.
Thank you, sir. So at the outset, I'd like to thank Professor Sridhar and Baxter Pharmaceuticals for giving me this opportunity to speak. So this is the last talk, I guess, for this session, and I'll be talking about the role of adjuncts, that is hemostats and sealants, they're used as basically in neurosurgery. Well, achieving hemostasis in any neurosurgery, be it spinal or cranial surgery, is like being a life in a balance, and tilting of the pendulum in either way, that is excessive bleeding or excessive clotting, can adversely affect the prognosis of surgery and thereby affecting the overall outcome. As a neurosurgeon, we need to be conscious that apart from the surgical factors, there can be a myriad of causes for bleeding in surgery, starting from surgical factors to platelet dysfunction to metabolic causes. So as a surgeon, we need to be aware of all these factors. So there is no doubt that in modern neurosurgery, a lot of people are now using hemostats and tissue sealants, and they are definitely useful, because they can minimize the overall blood loss during surgery, because they give you a clear field. It is very easy to resect the pathology concerned. They can definitely save operative time, because less time you spend during to attain hemostasis. Also, they can avoid unnecessary transfusion. They can they help us in managing anticoagulated patients, because hemostasis can be attained very fast. Sealants definitely help us to also prevent leakage of non-body fluids. Like if we apply sealants and space is sealed, so in some surgeries where the tight dural closure is not attained, then that can definitely prevent leakage of CSF. And all these factors ultimately decrease the post-op hospital stay of the patient, decrease the infection, and ultimately definitely causing a decrease in the overall cost of treatment, which is more important in private healthcare. Now, if we classify the bleeding during neurosurgery, they can be broadly classified into two categories. One, which we expect, depending upon the pathology, in which the bleeding can occur from the mucosa, the affected bone in case of meningiomas, or some vascular tumors. And the other category is the injury to the inadvertent vascular injury, mainly to major vessels during open and endoscopic surgery. Now, source of bleeding can be from superficial tissues or can be from bone, can be from dura, the venous sinuses, or to different parts of brain. Now, as a surgeon, while definitely keeping the sealants and hemostasis in use, it is very important to study the pre of radiology in advance before proceeding with the surgery. These are some of the cases where we can see that this is a very vascular meningioma with significant hyperostosis. Here, the sphenoid ostium, just the midland septum, the midland septum of the sphenoid sinus is deviated, and if we follow the septum, definitely, ultimately, it can cause disorientation. Here, the pituitary adenoma is encasing both the carotids. This is invading the cavernous sinus. All these factors we need to keep in mind and be ready to achieve hemostasis. Now, the journey of hemostasis, if we study, it has undergone significant advancement starting from the day bone wax was introduced by Victor Horsley way back in 1886 to significant adding of multiple agents. And the journey has progressed from different patches, fibrin patches to gel form, Surgicel, and ultimately the flowable sealants. While we decide which agent to use, we need to keep in mind certain factors. These factors definitely influence our decision about the use of sealants and hemostats. First thing, what is the area? What is the surface area? And what is the intensity of the bleeding? That means whether it's an arterial bleeding causing major arterial bleeding, or it's a venous ooze, or can be some diffuse ooze from the tumor bed. Whether the bleeding site is accessible or not. If in open surgery, it is definitely accessible. Sometimes if we are operating in very deep brain tumors or in endoscopic skull-based surgeries, accessibility is always an issue. And also it depends on whether the surface is raw or smooth. Now, there are various factors which decide and which guide us in choosing the hemostatic agent, starting from product cost to overall availability, how the product can be stored, what is the temperature, the duration, where it remains effective. The procedural applicability is always important. The format, what format it comes, and how to prepare it, what is the ease of preparation, how to deliver the agent more so in deep spaces, to how fast it attains hemostasis, also what is the durability, and the source. It is more important because in bovine agents, definitely there can be immunogenic reactions. And also finally, what is the absorption rate and does it cause swelling? All these factors ultimately influence our decision to choose a hemostatic agent. Depending upon all the factors which we have discussed, the ideal agent of choice is the one which is safe to use with increased efficacy, which is user friendly and comes at a lesser cost to the patient, and definitely which has got a better approving factor. Now, the adjunctive hemostats we use nowadays in modern neurosurgery can be categorized to two categories, that is active or passive. The main difference between active and passive hemostats are that the active hemostats function independently of the patient's coagulating parameters, and therefore definitely they are more effective, and they can be effective in a wide range of bleeding conditions. This is the normal cascade of hemostasis. As you can see, the main difference between active and passive products are that the passive products rely on platelet aggregation, and ultimately to achieve hemostasis, the patient needs to generate the clotting factors, and they need cooperation of the patient's coagulating machinery. However, in case of active products, it is not so. Now, the different active hemostatic products available to us are the flowable sealants, the T-seal, which is a fibrin sealant, and the advanced patches. And on the other category, passive sealants, we are using definitely oxidized regenerative celluloses, the gelatin sponges like Gelform, bone wax, hydrogen peroxide. All these things are passive hemostatic products. Now, irrespective of the agent we decide to use or the need to use, among all the available the key buttons in your keypad, is very important not to press the panic button. Rather, you should have all the hemostatic tools at your disposal in the OT, so that you can choose accordingly depending upon the situation. Now, the earliest effective, if you see the effective hemostat historically was the use of muscle, which was used first by Harvey Cushing way back, and definitely still a lot of neurosurgeons we use, and it can be a mechanical plus a source of tissue thromboplasty. And the main mechanism of achieving hemostasis is mechanical, where you can apply gentle pressure, and ultimately it can help us in attaining hemostasis. The other passive hemostat we widely use is Gelform. It was introduced to neurosurgical practice some 60, 70 years back, and it was basically derived from bovine. It is basically derived from bovine source, and it can absorb and can increase to many times its body weight, and therefore can cause mechanical pressure and help us to attain hemostasis. It can be used dry or soaked in saline, and however it works better when excess saline is removed as compared to supersaturate. This is the Gelform which we use. Also, we need to remember that the addition of thrombin or the saline helps us in causing molding to specific areas depending upon the site of bleeding. Also, it doesn't stick to globes, the instruments, and can be passed through the endoscopic instruments very easily. Hemostasis is moderate to fast if it is basically a venous ooze or a diffuse ooze. Mechanical pressure can definitely help us in attaining hemostasis. Causes very minimal foreign body reaction, that is a plus point, and ultimately it gets absorbed in 1.5 months time. Another source is avidin. Another hemostat we use regularly is avidin, which is a collagen derived from again bovine skin binds, and it can serve as a matrix for clot formation and enhance the platelet aggregation, degranulation, and thereby release the clotting factors, ultimately helping to attain hemostasis. However, in case of thrombocytopenia, as already discussed, this is not very useful. These are different brands of oxidized regenerative cellulose we routinely used. Neunit is not commonly used in neurosurgery. It's basically used in general surgery and neurological procedures. The main agents we use oxidized regenerative cellulose use are the Surgicel and Fibrillar. They were introduced way back in again 1940s, and it is the Surgicel, which what we commonly call the manufacturer Eticon, is polyanhydroglucuronic acid, which is formed by dissolving pure alpha cellulose in an alkaline solution. Ultimately, it regenerates into continuous fiber, knitted into gauze and oxidized. And when applied dry, it can absorb. It gets absorbed within 4 to 8 weeks. And ultimately, when it comes in contact with blood, it turns brownish due to the formation of acid hematine. The main advantages of oxidized regenerative cellulose are that we can use multiple times, multiple forms of application are available, mass form, neat form, it is plant derived, and tissue reaction is less, and also it has got bactericidal properties. The main disadvantage is there can be significant swelling, and the swelling can compress the adjacent vital structures, and also there is evidence of impaired bone healing. Now, the main mechanism of action of Surgicel is that it absorbs blood and becomes a gel, which basically it forms acid hematine, and ultimately results in formation of gel covering the site of vessel injury. And it can thereby causing local vasoconstriction, and ultimately it provides a matrix for platelet adhesion, accelerating the formation of the platelet plug that will form the foundation of the fibrin clot. It has definite bactericidal properties because the pH is significantly acidic, and under acidic conditions, as we all know, bacteria becomes less active, and this pH lowering effect remains until the material is fully absorbed, which is again a very helpful thing. Surgicel conforms to wound site with minimum sticking to the instruments, and it can cause effective hemostasis for a classic 6 to 8 minutes. And as we already discussed, the immunogenicity is very less. It has got bactericidal properties, and absorption occurs within 7 to 14 days. There are different studies available in literature. One study which I could find was published in Eurospine in 2004, where they have analyzed the utility of Surgicel and definitely advocated it. The fibrillar is the form which can be shredded, compacted, moistened, and folded. It comes in layers. Therefore, each layer can be peeled off and increased because there are multiple layers, so surface area is more. So it can help us in achieving hemostasis in irregular surfaces, even hard to reach areas. And surgical visualization is improved by the ability to cauterize directly through it, which is again a very helpful thing. Again, it gets absorbed in 2 weeks' time. This we don't commonly use in India, basically, so I'll skip it. The main complications of oxidized regenerative cellulose is that it can be a nidus for infection. It can cause inflammatory reaction. Antigenicity, especially in animal products, is more. Since the gelatin swells up, it can cause mass effect, and ultimately also there can be foreign body, which can be seen sometimes, and it can be a troublesome phenomenon. Now, while dealing with the different neurosurgical conditions, so there can be bone bleeding also, more so in meningiomas. The intraosseous vessels do not respond well to vasoconstriction, and therefore they rely on clot formation and physical occlusion for hemostasis, and therefore they can be achieved more so in endoscopic skull-based surgeries. If we are doing the surgery to the nose, one useful hemostatic tranexamic acid which can be used topically, and also while using the diamond bar through physical occlusion or surgical application, we can use a gentle pressure with a placet and help us in achieving bone hemostasis. The bone wax was discovered by Victor Horsley in 1892. It is useful and it is definitely effective in controlling the bleeding. Once smeared across the bleeding edge, there is immediate hemostasis. But the main drawbacks of bone wax is that it can inhibit osteogenesis, can cause an increase in infection rate, and it can remain as a foreign body for many years. Austin is again a steroid.
There's the last minute for you, please.
Yes, sure. So Austin again doesn't increase infection rates. Another agent which has gone out of use now is hydrogen peroxide. Use is very controversial, and recent evidence doesn't support its use in achieving hemostasis. This is the last part of the presentation where the flowable sealants are available. They come in mainly 2 forms. So one is the hemostatic matrix flow seal and a fibrin sealant known as T-seal. This is the history. Basically, the fibrin sealants came reported for the first time way back some 1 century back. However, in 1981 only, it consisted of human thrombin, highly stabilized human thrombinogen was introduced. The flowable actually create a granular hemostat that employs both active and mechanical components, which help us to achieve hemostasis. And it can be applied as a paste, which it is recommended that a gentle pressure can be applied for 2 minutes to achieve hemostasis. The main disadvantage is the allergic potential, and it can also swell to 20% of its the weight. The preparation time can be more, and immediately it cannot be used, and also cost is an issue. This is the literature where the different studies available in literature supporting the use of flow seal. The fibrin sealant is again fibrin glue, which is marketed by Baxter as T-seal and Johnson & Johnson as Avisil. It commercially available, and it has got really 2 components. One is a fibrinogen factor and one is a thrombin. After mixing, the fibrinogen is converted to fibrin, and the aprotein in it inhibits the premature fibrin degradation. So it can be used for hemostasis and tissue sealing to reinforce the dural closure and prevent CSF leak. Also in anastomosis of nerves and nerve grafts, it can be useful. And also it can be used to fix bone fragments to repair skull defects. Basically, the fibrin, while using fibrin sealants, we should keep certain points in mind. That it is not useful for severe brisk bleeding, should not be injected directly to the vascular structure. And clot longevity is comparable to both T-seal and Avisil. This is the basic mechanism of action, where you can see that flow seal can cause both active and passive pathways. Because of the gelatin, ultimately it causes platelet activation, and the thrombin present in it helps the coagulating pathway to generate fibrin, ultimately at achieving the clot. These are different studies available in reputed journals advocating the use of T-seal and flow seal for hemostasis. To summarize, the adequate hemostasis remains definitely one of the most important surgical principles. Selection of appropriate method, which is importance, and the advantages and limitations of each technique must be understood. Dealing with hemorrhagic complications requires different surgical skills that can be acquired in a stepwise fashion according to the level of complexity of procedures. Likewise, understanding the indications and current limitations of surgical technique may increase efficacy, may increase safety, and minimize the risk of a catastrophic hemorrhagic complication. The ultimate aim of surgery is always to paint a happy picture. The outcome should be good both for the surgeon and the patient. Thank you very much for the patient.
Thank you, Dr. Sharma, for a very comprehensive but elaborate discussion. And it was very important, actually. Many small things which I also didn't know. Thank you very much. I think with this, we come to the end of the talks. I'm just wondering whether we should first take up the question answers from the audience, which might be, to stimulate them that we have given importance to their queries. So that is what I'm going to start with. There are quite a few questions, and the first one I see: does the neurosurgeon needs to undergo short sonology course for interpretation intraoperatively? I think Dr. Ali Asgar can answer this, but obviously I can definitely say that yes, everybody needs to go through a sonology course to have better orientation. Dr. Asgar, are you there, please?
Yeah, Dr. Ashish.
Yeah.
Yeah, so I think the point is that with any technique and any adjunct, you need to be well trained, because unless you know what you're doing with that adjunct or that tool, you're not going to be able to use it well. And more so maybe with ultrasound, because there is a lot of subjectivity, both in the acquisition as well as in the interpretation. But here a word of caution that if you see a formal course, what radiologists do in sonology, it's good for the theoretical part, how to do the ultrasound, but the interpretation bit of it, I guess, and in my experience, I've seen it, and radiologists will admit that they themselves, for the intracranial ultrasounds, they usually are good with the semiology. When I say semiology, means this is hyperechoic, that is anechoic. But the anatomy, the anatomical and the pathoanatomy interpretation, I think neurosurgeons, we can do them equally good. It's a matter of getting used to it, practice. I think the best course for a person to do is just use the ultrasound in all your surgeries, even if you don't require it to insonate a tumor, or you don't require it to do a resection control, just use it, because you'll get familiar with it and you'll be able to understand what different things are. And maybe if you have navigation with it, what it helps is that it gives you that orientation, it bridges or shortens the curve a little bit, and you can do it. Most of it is self-learning. So yes, a formal training is good, but a lot of it can be done by self-training also, I think.
I think that's a very important point. I am happy to see that you have got the SonoWant, which I had the experience to use in Sheffield in the year 2008. They had SonoWant in those days. Yeah, and one of the important things that what I would like to emphasize from whatever I had experienced is that the artifacts that you mentioned in an operative field sometimes can be very misleading, and you cannot really make out very well. But I believe that
absolutely
latest generation machines might be better, but I had been exposed to that a long time back, but I don't have it now with me here. I think the next question, if I go to the next one, is also pertaining to your, where is the question gone?
Any advantage of contrast in
Yes.
Contrast. Yeah. Yes, absolutely. So contrast ultrasound is actually a very exciting new technique of doing ultrasound. So I think ultrasound is a gamut of techniques. It's 2D B mode ultrasound. You have Doppler, you can do Doppler angio, and very good angiograms you can get, and it's real time. Then you have contrast ultrasound, then you have elastography. I think these are all very complementary adjuncts, different ways of interrogating the tissue or the tumor. And the advantage of contrast is twofold. One is in tumor surgeries to detect residue. There's a lot of interest in even characterizing tumors, but that's more academic research. And the second application is in angiosonography with contrast, because unlike Doppler angiography, which shows you medium to large size vessels, with contrast bubbles, you will be able to even see the microcirculation and the perfusion. And it's actually very, very reliable, and it's all real time. So yes, it has a role to play.
They also have, somebody has asked about the size of the probe that you use. So
Yeah, so the probes actually have to be smaller for cranial application. You can't use the big ones, but remember that within the exposure that you have, you should use the largest probe available, because the larger the footprint of the probe, it is the best resolution. So generally, the probes that we use are cranial probes. Most of them are around 2.5 centimeters footprint. And then you have the smaller burr hole probes. But then, as I said, the smaller the probe, you will fit it into the burr hole, but your resolution field of view is going to be small. So, and generally when you do gliomas or interaction surgeries, you, of course, I know there's a lot of the literature now of minimally invasive surgery for gliomas, but most of the times your craniotomies, if you're mapping and you're doing multimodal, will be big enough to accommodate an ultrasound probe.
And conventional or navigational intraoperative ultrasound of more use in glioma resection. So obviously, I would
I
say
think
navigation.
both are good. The navigated ultrasound, as I also mentioned in my talk, will give you some advantages. But the crux of the navigated ultrasound, still the backbone is still the 2D ultrasound that you're acquiring. You are just integrating it with a navigation. So unless you do that well, and you have to interpret that image eventually, so it makes it easier using navigated. And because you have to serially compare scans, when you're doing tumor resection control, what you want to do is you want to check the scan at few intervals, and you would like to compare it with the previous one. Especially you mentioned, Dr. Ashish, about the artifacts. One of the ways to avoid artifacts is to compare it with previous scans. And when you see newer things coming up, they were obviously not tumor, because it would have been there earlier then. And to do that in a point-to-point manner, you need co-registered, preferably images. And with doing only 2D ultrasound, sometimes you have to make a mental image of that. With navigated ultrasound, it becomes easy. So that's why you can extract more benefit out of it and avoid some of the mistakes with that. So both are useful, but navigated has those benefits with it.
I think one of the important things is the field has to be absolutely dry, as much dry as possible. That is one of the important things. Um, the next question is that how do you differentiate blood, air, bubbles from hyperechoic areas of the tumor? I think that's by experience, but if you want to add something more.
Yeah, no, as I just said in the previous explanation, that blood and air will actually give you a complete shadow. It's the enemy for ultrasound. So you don't want any air. It will throw a shadow behind it, it's air. And blood is going to be hyperechoic, but it will be much more hyperechoic than tumor. So you compare it with your intermediate scan. That's why it's always good to do the scan before you finish your resection, so you know what the residual tumor without artifacts looks like. And then when you finally done your resection cavity, you will have micro contusions of blood which are extremely hyperechoic, not as much as the previous tumor was. And that's how you also differentiate whether it's truly residual tumor or it's hyperechoic artifacts. And then there are some other ways to do it. You can insonate by directly putting the probe into the cavity wall, or by insonating from the adjacent normal brain, which eliminates some of the artifacts which happen when the rays pass through the cavity. So there are tips, there are different tricks, and all of them can help you. And the more you do it, the more you'll, I guess, get better with it.
The next question, I think, is for Dr. Punia, which says, is it indicated to do awake craniotomy in patients with brain tumors near eloquent region with midline shift and raised ICT?
Yes, we can do, provided the patient is cooperative and is not drowsy or in an altered state of sensorium. The patient is cooperative, why not? We can do.
I think the issue he might be saying is that the raised ICP is that the brain pouts out, and how to manage that sort of situation. Probably that he's indicating in this question.
Yeah, usually in brain tumors, we routinely see this. It evolves over a period of time. Unlike a head injury, it's not an acute scenario, so it can be managed intraoperatively.
And obviously, the next question you've already answered. It says, can
Ashish, I'll just add, if I may, a little small point in that.
yes,
We all have done, sometimes large tumors, midline shifts, but we don't really, when we have a good uh, management, intraoperative management, anesthetically and otherwise, we don't really see the brain bulging like, we used to see long back, maybe 30, 40 years ago, but we don't see that now. With good anesthesia management and
you.
management,
Yeah, it
we
depends on.
very rarely
Yeah,
see that.
I would say in a different way. For routine patients who are planned, we give steroids and prepare the patient. The brain is relatively quiet. But there are emergency, probably he is mixing up the two situations. There are emergency situations, the patient come unconscious with a massive edema. Yeah,
Yes.
yeah. So those are not the patients for anyway for, so things like that.
So maybe can I make a comment here,
Please,
Dr.
please.
Ashish? So
Yeah.
one of the indications for such kind of tumors is to do sleep wake if possible, so that you can do a sleep with LMA if you have, and then you can rapidly debulk the tumor to relax the brain. Of course, you will not do the mapping at that point of time, but you rapidly debulk and relax the brain, and then you can do your surrounding cortical mapping to get the resection margin. So I think that is one of the indications besides large tumors like insula or something where you're doing awake, whereas sleep may be actually better than just awake. But
Yeah,
yes,
but
you're right, Dr. Bonaya. If there is patient is uncooperative, sensorium is not good, I don't think it's the right thing to do awake, because it will not serve the purpose that you're doing it for.
Yeah, we're talking about emergency situation, and we need to have the team
I
in
think,
place. And
yeah.
so we are not getting into those cases. What are the other questions I'm trying to? A lot of questions. That's good.
Dexmed be used
Yeah,
infusion
I think that
for
has been
awake.
answered.
That's
That has
being
been
commonly
answered.
used in.
Yes.
Yeah.
Although in our center we don't prefer it because we wanted a very clear-headed recovery. If you compare Dexmed with propofol, this propofol, when you stop it, it produces a very clear-headed recovery, and the patient will be in his full sensorium and clearly speaking. Dexmed, somehow there will be some residual effect and their speech and other things maybe little. It's all an individual experience only. Like I told you, there are different ways and the different people prefer. It's how you use the drug than what the drug use itself.
Then the question which says, can subcortical
For all our
mapping?
awake craniotomies.
Sorry.
Yeah, and actually the preferred would be even better would be remifentanil if it's available, and it's pretty expensive. So that is really a good analgesic, plus it will wake up the patient as soon as you
Very
stop the
quickly.
drug.
Yes.
So Dexmed, remifentanil, and then propofol. So as per your convenience, whichever you're happy with to use, I think that's okay.
Remifentanil is not available here, though it is already in use for last 10
No,
years.
it's not available in our country and it's very expensive. Yeah.
Yes.
North America, it's used very commonly.
Yeah. In UK also, NHS, they use it routinely. Now, can subcortical mapping serve the purpose of DTI in tumor resection other than
I think
preoperative?
Anand has replied to that in a very nice way. With the DTI, you know what fibers are lie under your tumor or in the anterior or deeper margin of your tumor, and that's when you use your subcortical stimulation and other things to ensure that you are not destroying a fasciculus that you want to preserve. So I think, like he's written it, they are complementary. You need to use all these together to save the patient.
I have heard people ask me, why do functional MRI if you're going to do brain mapping? So it's very important to know where to start. When you are exposed with the field, you wouldn't be having a clue which way and you'd be in a blind search. It shortens your time of brain mapping if you have done a functional MRI and you know what to expect where. So I think it's very crucial to have all kinds of information. Sometimes your mapping will not work, so you will stimulate, your stimulation may not work, so you will be lost. You don't know which is the area which is eloquent. But at least if you have functional MRI, you can map that area navigationally before you start, and then you know, yes, that is the area to be preserved. You may leave some tumor behind on that direction, but it gives you valuable information. So I think each one will supplement the other very well. So please use all the techniques that you have at your disposal and don't give up one saying is inferior to the other.
And also, if I can add that a lot of radiologists use the fMRI to generate the ROIs to seed for the DTI. So so it's actually quite a reliable technique to generate that DTI. Otherwise, it becomes a little random. But that is one of the other uses of doing fMRI.
We do that regularly for our navigation DTI fiber tract navigation. The other imaging which is available, probably more advanced, is the navigated TMS derived fiber tracts. So
Correct.
TMS is almost like transcranial magnetic stimulation. It's almost like brain mapping intraoperatively. So you know exactly where you stimulate to get
Absolutely.
the desired problem, I mean, or the desired effect, motor, sensory, language. And you can fiber track from there using the DTI, and that will be even more specific than trying to merge the two together later. So that is another advanced imaging modality available. And one more I would add for Dr. Sridhar probably is the perfusion study. It may not exactly fit into functional imaging, but MR perfusion is pretty useful imaging modality, especially when you're resecting tumors, to know which area needs to be 100% out of the brain, you know, especially in low-grade tumors or non-enhancing tumors. You may leave behind some area which are hyperperfused, and or if you're doing a biopsy, you know which area to take the biopsy from, because you know that is the highly metabolically active area. Spectroscopy we know is very relative, maybe specific, non-specific, but perfusion is a very useful clue, especially when you're dealing with low-grade progressive to high-grade tumors.
The other usefulness of perfusion is also to differentiate, progression
Yeah,
of tumor
that's
versus
true.
Post-op.
Yeah, radiation necrosis versus
perfusion
recurrences.
very useful in all that.
Yeah, exactly.
We have not, obviously the time doesn't fit in. The other thing for Brainstem, of course, this needs a separate session altogether, is neurophysiology, electrophysiology for brainstem lesions. So that's a totally separate lecture altogether, to be honest. So that's another very helpful tool, which might be very much useful in certain strategically located lesions, brainstem near the optic pathway and other things like that. The other thing which I wanted to mention here was that I use this DTI imaging. If it is already showing destruction of the lesion, I use it to show it to the family, sit down with them and explain to them in a very simple language that this is what was there on the other side, normal side, and this is there. So they themselves are also oriented to the outcome much before, they have any apprehension that's gone. This is destroyed. I can't help it. But obviously, we're going to do whatever best is there for the patient. So I use it also as counseling with the images to the patients if I got a good DTI image. So that I routinely do.
Dr.
Right.
Ashish, since we are on fMRI, can I make a comment?
Yes, please.
Yeah, so I think one thing about fMRI that we must realize is that it depends a lot on patient cooperation, because it's the task that the patient is going to do, and the signal to noise ratio is crucial. And also that it will only show you the functions that you are testing or the paradigms that you use to do the fMRI. So there is a completely new field of resting state fMRI now. That means that the patient, even young children who are not cooperative, or patients, especially brain tumors who may not be cooperative, you can generate functional MRI in the resting state without having the patient to do a task. And it's based on a slightly different principle of having synchronously firing nodes in the brain, which will pick up. So it actually picks up connections or networks rather than just single areas, which is also an advantage over task-based fMRI. So I thought since we are talking about that, it's worth mentioning it.
That's important.
And actually, there is a ongoing study which a couple of people are doing from Bangalore, based on resting state fMRI, and then taking it on to AI and trying to get more information out of that. So that's
Right.
all future, I think.
Yeah. Ultimately, everything is AI now. Now, hemostasis.
Next question is, can we rely on fMRI for language lateralization more than WADA test in epilepsies?
I'm not aware whether we have achieved that sort of, confidence. But I think that's
no, it is. There is literature to say concordance is very good, especially where there is good dominance. If it is pure left hemispheric or pure right hemispheric, it can easily be picked up with the functional MRI. But if it is bihemispheric, it could have problems, because you don't know. Actually, WADA's test, if one really sees, gives you a mimic of what happens when the lobe is knocked out.
That's
So
all.
you actually study what is left behind rather than just picking up language dominance. So if somebody has bihemispheric dominance or somebody has, say, neuropsychological dysfunction in both sides of the hemisphere, you knock off one hemisphere and then see what is left on the other side. So that's where the function of WADA's test is. So the question you ask has to be very clear. And if the question is simple dominance, where is the language area? As long as it's left or right, I think functional MRI can give you a good idea. But if you want more to be answered, WADA's test still has a lot of relevance, which functional MRI can't do.
There's a question on hemostasis after ICH evacuation in hematoma cavity. Packing with Surgicel. I think we line it with Surgicel rather than pack it with Surgicel. So that's the way I would sort of put it.
I would just give a caution on packing with Surgicel or with Fibrillar. They do tend to form a hygroscopic mass, and sometimes if it is too tightly packed, you can have like a nice hematoma seen in the post-op scan with mass effect as big and as effective mass effect as the old original hematoma itself. So I think there is no shortcut to good irrigation of the cavity and lining the cavity, as Dr. Ashish rightly said. You can fill it up with Surgiflow or something, but you need to wash off the excess. Contact with the bleeding surface should be washed out and should not be unnecessarily left behind.
Yeah, I routinely, after my pituitary surgery, I put Surgicel and wash it off. So all the lining with the flow seal does the job for me. I had experience of not doing a good diathermy coagulation of bleeding vessels and lining with Surgicel. And obviously the bleeding went on beneath the Surgicel. And next day, as you rightly said, the Surgicel was all pushed to one corner and it was all full. So first of all, the direct coagulation of the major bleeding points has to be addressed to first before we think of just aligning with Surgicel or any other agent. That is very important because it's very sort of disheartening to see all your hard work goes down the drain with a big hematoma sitting there.
Sir, may I ask one question?
Yes, yes.
Yeah, sir, they're obviously very experienced faculty in the panel. So I'd like to know from your experience, what is your experience of using FlowSeal in endoscopic skull-based surgery with major rent to the vessel? Because recently, sir, I was doing pituitary. It was a large pituitary extending into the cavernous sinus, and there was a rent in the ICA. And ultimately, I was successful in achieving hemostasis with FlowSeal. But the patient came back after a few months with large pseudoaneurysm. So is it really effective, sir, in major rants, in major vessel, big rants in major vessels?
I would have definitely tried to seal it up in whatever way you tried, that's fine. But the next thing I would do is go for an angiogram
Yes, sir.
and pick up if anything is in the offing much before you see the patient. You are lucky if the patient has not ruptured that pseudoaneurysm
No,
because
it didn't rupture.
it didn't rupture, so you're lucky.
But
Otherwise,
definitely, yeah.
I will pack it and then take the patient up for an angiogram.
I think in endoscopic pituitary surgery for large vessel bleed, the most time tested will still be a muscle patch. If you can get a muscle patch on the large rent, I think that will be the best way. And on top of that, you can put whatever sealant you want. I want to give my share of complications that I have had with large vessel bleed in the pituitary surgery by using hemostatic agents. We had packed and nicely thought that it's all good. I didn't use a muscle patch at that time. And lo and behold, post-op, when we woke up the patient had, and we immediately did the intraop MRI, means as we had extubated, it would be ideally an extraop. But because MRI was just next week, we just got a scan done, and you could see peppered with infarcts, embolic infarcts all over the territory. So all the coagulating agents that we use, if there is a large rent in the vessel, unfortunately, that case was infiltrating in, and I was using QSAR, so it had made a hole into the carotid, and And that was a very bad thing to have, because patient survived, did well, but had a stroke on the dominant hemisphere, and still cursing me today, and I keep cursing myself for using that. I think muscle patch would have done good, and any sealant over the patch is better than using any of these particulate agents directly on a major bleeder. They work very well for diffuse wounds in areas which you cannot reach. But for large bleeders, I think first is get the pack in place for a good muscle, and then over that, use whatever else you want.
I would follow it with the angiogram and necessarily then a stent
Yeah,
or something
exactly.
like
Yeah.
that. Supplement that defect. Yeah. Well, I think any
I'll
more
give
questions?
some comments for on Dr. Ali's talk. As usual, it was very good, Ali. Nice to hear you speak with the new Brain Lab 3D navigated ultrasound. My question one was to know what is the difference between the Electa 4D navigable ultrasound you had and this 3D navigable Brain Lab ultrasound that you have now. What do you feel is the difference? Both are equally good, or you find the Brain Lab better?
I think slight correction. The Sono one is also actually 3D only.
Okay.
So in terms of, since I was very used to the Sono one many years, but unfortunately the company just wound down, and they have started again, but I think they have a very limited team now. So it's a very good device. It's customized just for cranial application, and the interface is very useful. The advantage of the Brain Lab is that it has a very strong navigation platform. Means you could do the DTI, and you can do a lot of other things which were not possible on the earlier Sono one. And you have a very powerful ultrasound scanner, BK. That's a different one. So you have to integrate the two. The problem is you have to integrate the two. But if you integrate it digitally, and the Sono one had the advantage of having an inside, it was just inbuilt. The scanner is actually within the navigation system.
Okay.
So that was the big advantage. And of course, when I switched over, because Sono one was no longer servicing, our old Sono one still works, but it has limited functionality. To get used to the new workflow is different, because the workflow on the screen is different. You have to go different, but eventually, yes, I think it works very well. The scanner, ultrasound scanners are extremely good. The new ones with BK, and I think a lot of other companies now have very good ultrasound scanners. And the key is to select the right probes, and they all have very good dedicated cranial probes. And if you adjust the parameters well, you will get a good ultrasound scan. So I think it's useful.
I think that's very useful information, because I think Brain Lab has done a good job in this 3D navigable ultrasound. The competitors still have a 2D ultrasound, which
yeah. So actually, the other advantage of Sono one, since you mentioned it, is that it is truly navigated on the ultrasound, which the Brain Lab still does not do. That means that I can pick up the ultrasound, which has the tracker on it on the Sono one, without having done an MRI at all, and directly start navigating with the ultrasound. So that is very useful when you don't want to waste time getting an MRI to register. You don't have to do registration with MRI at all in the Sono one. The only disadvantage of that is that you have to have a mind which is already oriented based on the ultrasound, and then you can go ahead and do all your navigated. So that's what we called, when we published it, as direct navigated.
You don't fuse it with the, so you don't fuse it with the pre-op MRI.
You don't fuse it at all. You just directly, yes, you directly navigate with the ultrasound, which the Brain Lab cannot still do.
It's such a pity, such a wonderful equipment with piece of software which can be so useful, is not commercially made viable for us to use.
Yeah,
the other comment I had one very unfortunate. Yeah, one slide which you had shown, Dr. Ali, towards the end, saying false negative on MRI, which was picked up on ultrasound. I just wanted to understand that. I mean,
so actually, I ran through that. So when we analyzed our data, there were false negatives in the ultrasound, which means that the ultrasound didn't pick up the residue, and the MRI, post-op MRI, showed it. And then we
I thought it was the other way. Yeah.
No. So actually, we've had some of the other way also, and you can argue that the MR had not picked it up, and the ultrasound. But who is right, you will never know unless you do histological evaluation.
Exactly. That was really interesting for me to know that MRI.
So we've actually done a histological evaluation. We've still not published it. We actually did a randomized study looking at sono-navigation versus navigation, but it's still under analysis, so I cannot disclose those results. But we did a biopsy also of the cavity to check for the accuracy. But interestingly, in the false negatives that we had with ultrasound, what we found was that most of them were near total resections, which means the ultrasound might miss some of them, but they are almost thin slivers which are picked up on the MR. And you have to assume that the MR is the gold standard and MR is not showing some post-op change, etc., which can be argued either way. So
I think, as you rightly said, the ultrasound has its wonderful advantages being truly real time, which MRI doesn't. And every time I stop to do an intraop MRI, I curse that 1 hour nearly of the downtime, in spite of all the information we get and all the good job we can do with intraop MRI. But one note on the cost effectiveness, I think with the 2-room models coming up more, and radiology utilizing the MR very well, the cost of intraop MRI is really not high. So it's not a dedicated OR brain suite anymore. It can be easily incorporated with the radiology and the OR next to each other, with radiologists sharing your burden. In fact, they'll take away the burden very fast. In 1 year, they will do more scans than you can operate ever in your lifetime. So they will get the money back for the hospital, and you can still keep using your MR without any burden on you to recoup the money. And even for the patient, the cost effectiveness works down very, very low. So I think intraop MRI is still viable, and it can be used wherever it is possible. And
so what I feel, sorry, is that that's an important point, because the MRI still is the best way to pick it up. So I think a good idea would be combining ultrasound and MRI. That is, you use ultrasound repeatedly till you do the final check scan, which is where you would do the
I think
MRI.
that will be the best. That will be the best that a patient can get, and time effective it can be. Intraoperative imaging, another advance I wanted to point out here, apart from fluorescence, which ALA is there, and yellow fluorescence is there, and Ali, your article, I would like the audience to read on the CP NSI list of publications, beautifully written of intraop imaging and comparison of all the modalities. One modality which I came across and which is coming up very well is Conveyor. So Conveyor microscopy is now commercially available with a probe which you just have to touch at the margins, and you need a pathologist who can read a black and white image and come up and say it is tumor or it's normal tissue. I think with more and more pathologists getting their eye in, probably Conveyor is attached to Kinovo new Pentro microscope system. I think that will be a wonderful way of analyzing tissue in vivo without having to send even for a squash. So you can look at your margins very clearly. At least you will know whether the tumor is fully resected or not. It's not only for neurosurgery, it's applicable in any tumor anywhere in the body, and it can be reported virtually from anywhere in the world. So I think that's a very interesting intraoperative advancement. I remember, Ali, you talking about Raman spectroscopy. I think that is yet not yet commercially common, but Conveyor is in there, and I hope some institutes will pick it up and will be able to work on it.
Having said that, let me give a final comment. There was a professor of medicine who had a large occipital GBM, and he himself picked up his own diagnosis. He said, I cannot read from one side, and that's how he said something wrong. And he told me, you chop this lesion such a way, take all your margins. I've read everything about GBM. He's professor of medicine, retired professor of medicine. And I want good cleavage and good margin. And I know that 2 centimeter margin is considered, must be sort of considered. So, okay, I did that. Everything went fine. Post-op, absolutely clean MRI, no lesion. Obviously, the occipital lobe is gone. Lo and behold, 8 months later, he has got a new lesion coming in the temporal lobe, miles and miles away from the original site. So we still don't understand. Whatever you do, the neurobiology is something still alluding to all the basic things that we need to know.
Any
So
other comments? Dr. Sridhar, you want to add something?
no, unless I think if we can wrap it up.
8:25. I think audience must be bored by now.
So thank you all very much for this excellent webinar on adjuncts in brain tumor surgery. As usual, we are putting up all the recordings of all our webinars on our YouTube channel of our institute, and their call can be seen there. So thank you all very much. It's been excellent having all of you, and see you same place next month for another Tumor Thursday webinar. Thank you so much.
Thank you so
Thank
much,
you.
Dr. Sridhar. Bye.
Thank you.
Thank you.
Bye-bye.
Thank you, sir.
Thank you so much. Have a wonderful evening. Thank you.
Bye-bye.
Thanks to Baxter for sponsoring this.
Thank you, sir.